baby could move her forearms and hands sideways and had a weak grasp. So what is the importance of this? So this line is, or you can say this statement is very clearly making an impact that this baby has a proximal weakness. So the baby is making attempts to moving her arms, could not lift her elbows, but she could move her forearms and hands sideways and at a weak grasp. So this is suggesting of proximal weakness more as compared to distal weakness. Similarly, in the lower limbs, there was no spontaneous kicking movements, but she could move her.
Recording in progress.
Similarly, in the lower limbs, there were no spontaneous kicking movements, but she could move her feet and toes and could minimally lift her knees from the bed, but had no movements at the hip. So again, the movements at the hip were limited, but she could make her movements at the feet and the toes. So again, this statement is giving an impression of more of a proximal weakness as compared to distal. Then mother also noticed that the baby had generalized floppiness for the last 2 months. So you can say these two statements are very important and making an impact that the proximal weakness is more as compared to distal. And this should be very clear from your history that which weakness is more, is it proximal weakness more or a distal weakness more. Then there is history of weak crying which has been present since birth, which has been given the history given by the parents. Then the history of prolonged period of sucking during each feeding session since birth. So what do we mean by this prolonged period of sucking? So that means there is difficulty in swallowing. So the muscles are affected, so there is difficulty in swallowing, and this is leading to prolonged period of sucking during each feeding, which has been again noticed since birth. Now the baby has presented with feeding difficulties with weak suck and frequent cough during feeds, which has been aggravated over the last 15 days. And third complaint of respiratory distress or difficulty in breathing in the form of rapid breathing and chest retractions, particularly over the feeds for the last 5 days. So 2 months, 15 days, and 5 days. This is the chronological order of weakness. Then there is history of not gaining weight since birth. Now, important things you should rule in the history: no history of persistent fisting, no history of seizuring of legs. So again, these negative things point out that there is no central cause. So ruling out the central cause in this, no history of seizures or tonic posturing, suggesting that there was no asphyxial damage or asphyxia during the birth. No history of any increase in head size noticed by the mother. No history of increased sleepiness or incessant crying. No history of drooping of eyelids. So again, as this is a floppy baby, hypotonic baby, clear from the presenting complaint, so you should have to rule out certain important things like congenital myasthenia or congenital muscular dystrophies or congenital myopathies. So no history of drooping of the eyelids. So like in congenital myasthenias, congenital myotonic dystrophy, there is a lot of facial weakness plus ptosis, ophthalmoplegia. So this history is again asked for these, ruling out these conditions. No history of drooping of eyelids. No history of abnormal eye movements. So ptosis, ophthalmoplegia, ruling out certain conditions like congenital myasthenia, myotonic dystrophy, congenital. Baby is able to watch the mother's face with intent while feeding and when being spoken to. So this history suggests that baby is recognizing the mother. Then there is no history of facial asymmetry while crying. Baby recognizes mother voice, looks to loud sounds with minimal sideward neck movements. So minimal neck movements, again suggesting some sort of muscular weakness. Baby reacts to changes in temperature. No history of any lethargy, forehead sweating, bluish discoloration, suggesting ruling out any congenital heart disease. So this history is suggesting out ruling out any congenital heart disease. No history of fever, vomiting, loose stools, abdominal distension. No history of abnormal order or abnormal order of urine, ruling out some metabolic disorders. So history suggesting to rule out metabolic disorders. Now, when we have taken the presenting complaints, we have taken the detailed history of presenting illness. What is the pattern of weakness? Which movements are more of affected? What is the pattern of respiratory involvement? Ruling out certain important disorders by negative history. Then the antenatal history. So this was a third order pregnancy. First and second pregnancy were uneventful. This is the third pregnancy, which is the child is a product of this third pregnancy. Important trimester wise history. Ruling out any medical illness in the first, second, and third trimester. In the second trimester, there was no history of diabetes, gestational hypertension, or hypothyroidism. Quickening, this was felt at you can say at normal time, 4 to 5 months. Now, this is again a very important history. You should always ask this: was the anomaly scan done? Yes, the anomaly scan was done at 20 weeks and it was normal. So parents are very much aware of the if anomaly, if any noticed during the antenatal period. So you should always lay stress on this history. Was the anomaly scan done? Was it normal or abnormal? Third trimester, mother had anemia and she had taken iron injections for the anemia. Then no history of any bleeding per vaginum, foul swelling discharge, UTI. Now this is again a very important history. History of decreased fetal movements. So this was, you can say, some positive history which was given by these parents during the third trimester, and this suggests there was some sort of muscular weakness or fetal weakness which had already started during the intrauterine life. So this suggests that disease had its onset during the intrauterine life. No history of any other drug intake. Then the natal history. So mother went into spontaneous labor 5 days prior to expected date. No abnormal presentation. Full-term baby, 3.09 kg. Immediately cried. Breastfed within 1 hour of birth. Urine and meconium passed within 24 hours. No NICU admission. So all these things, you can say, all these things you had to ask, since the baby, the onset of the disease is from the intrauterine life. You had to ask all these things in the detail: the antenatal part, the natal part, and the immediate neonatal period. So you have to ask all these things in the detail. Immunization history, not significant, but doses of vaccines given, 1.5 month immunization done. Now this is important: developmental history, gross motor. So this is the 3 months child, and we expect the child baby to attain the head control or neck holding. But in spite of this, the baby had not gained the head control. So you can say there was delay in the gross motor milestones. So there was delay here, but the fine motor, social smile attained 2 months, recognition of mother was there, and vocalization was there. So you can say there was an isolated delay in the gross motor milestones. And what it could be due to? You can say this isolated delay was predominantly due to muscular weakness. Family history: no history of any consanguinity, no history of seizures, developmental delay, or developmental regression in the siblings.
బాగా
So
పడుకున్నావా
why this?
పెగ్గి? బాగానే పడుకున్నావు
Ruling
కదా?
out any, you can say, neurodegenerative or any neurocutaneous
నిద్రకు
disorder.
వస్తుందా?
There may be a family history of some neurological disorder. So there was no history of any seizures or developmental delay or regression in the other siblings. Then no history of any neuromuscular disorder in the family. Why this? Because you can say myotonic dystrophy, the congenital myotonic dystrophy babies, which present very early in the neonatal period, they are born to the mothers with myotonic dystrophy. Then transient myasthenia. This condition is seen in babies born to myasthenic mothers. So there was no history of any neuromuscular disorder in the family. You should have to ask this history when there is a floppy baby which is present immediately in the neonatal period. So this history is asked for this. No history of any ptosis. Similarly, again, ptosis seen in myasthenia and myotonic dystrophy. So this thing was again not positive in any family members. No history of any unexplained early death in the extended family. So basically, you have to rule out some important conditions which can cause or lead to floppy baby presentation immediately in the neonatal period. So why you are asking the history, you should know what conditions you are excluding, you should know. General examination. So always Start with the posture. Baby was awake and alert, interested in the surroundings. So, awake and alert, interested in the surroundings. This is again pointing that the higher mental functions, or you can say cognitive domain of this baby was normal. The baby was mentally looking normal, awake and alert, interested in surroundings, recognizing the mother, responding to the mother. So this domain was okay with this baby. Responding to examination with feeble cry. So again, there was a history of weak cry since birth. So the baby was responding to mother, but with a very feeble cry. Looks ill-nourished or malnourished with loose folds of skin, as seen in the picture. Now posture. Always when you are telling the examination in the front of the examiner, always look at the posture and describe the posture then and there only. Do not describe the posture as it was at the time of examination. Describe the posture as it is there in the front of the examiner. So the shoulders externally rotated. The shoulders are externally rotated, arms abducted with elbows flexion and hands kept by the side of the head. So this is how I have described the posture. Shoulders externally rotated, arms abducted with elbows flexed and hands kept by the side of the head. Hips again partially externally rotated with minimal flexion of the knees. With minimal flexion of the knees. So describe the posture as it is you are seeing or watching the baby in the front of the examiner. This is again a very important thing to be described. Now anthropometry. Again a very important part of the examination. Weight of the baby was this against expected of this. Now this is not sufficient. You have to interpretate the anthropometry then and there only. Interpretate this. This is the weight for height or weight for length, as this is a 3 month child, less than 3 standard deviation, and the baby is severely wasted or severe underweight. So give the interpretation. Length 56 as compared to 59, 0 to -2 normal. Head circumference 0 to -1 standard deviation normal. So the main interpretation is weight for length is less than -3 standard deviation, and this comes as the interpretation as the baby is severely wasted. So this is how you describe the anthropometry. Chest circumference 36 centimeters. So less than 1 year, you also try to take the chest circumference. Why? Because there is a relationship between head and the chest circumference. Examiner can ask you what is the relationship between the head and the chest circumference. At birth, head circumference more than chest circumference by up to 3 centimeters. So you can say head minus chest. The difference is, you can say, less than 3 centimeters. Head is more than the chest up to 3 centimeters till 1 year of age. Around 9 months to 1 year, they equalize. Head circumference becomes equal to chest circumference at the age of 1 year. But after 1 year, the chest grows more rapidly compared to the brain. So this is the relationship between the head and the chest circumference. This you should know. Why? Because there are certain conditions where head is disproportionately larger than the chest. And the difference is more than the 3 centimeters. What are these? So the head circumference is greater than the chest circumference by more than 3. So you can say head minus chest is more than 3 in 3 important conditions: preterm, SGA babies, and hydrocephalus. So these are 3 important conditions where the difference is more than the 3 centimeter or head is disproportionately larger than the chest. In malnourished children, the chest size may be significantly smaller than the head circumference, because the growth of the brain is less affected by undernutrition. Why? Because in malnutrition, the chest may be more affected and the head is relatively preserved. That is why there will be a considerable delay before the chest circumference overtakes the head circumference. So head is relatively preserved chest is more affected, so there may be a little delay before the chest circumference overtakes head circumference. Now again, a very important Viva question. You can say recommended criteria for identifying SAM in more than 6 months, less than 6 months. What are the criteria to label the SAM? This we all know is very simple. Weight for height less than 3 standard deviation, 1. Visible severe wasting, 2. Mid-arm circumference less than 11.5. Edema. Remember, it is nutritional edema. It is nutritional anemia. You have to rule out conditions like nephrotic syndrome. So it is a nutritional edema of both feet. Any of the criteria present, we label the child as SAM. Now the criteria for identifying SAM in less than 6 months. Again, it has been divided into two categories. Length of the child baby more than 49 centimeter, length of the baby less than 49 centimeters in there. If the length of the baby more than 49 centimeter, then the criteria are simple. Again, weight for height less than 3 standard deviation, visible severe wasting, nutritional edema. So here we have not taken MAC, obviously. And for children with length less than 49 centimeter, only criteria which is taken is visible severe wasting. Remember, for a child less than 49 centimeter, only criteria is visible severe wasting can be used as a criteria to identify the SAM. So again, this is one of the important Viva question which can be asked during the case presentation. Then coming to head to foot examination in this child. Head, normal size, normal shape, no micro or macrocephaly, no low-set ears, low hairline, it was not seen. Eyes, normal, no hypo or hypertelorism, no upward or downward slant in the eyes, no prominent epicanthal folds, no cataracts. So the eyes were normal in appearance. Oral cavity, again oral cavity, lips and philtrum normal, no high arch palate. Important, very important finding. You can say tongue fasciculations. You cannot miss this finding in a floppy baby. So the tongue fasciculations present. You cannot just miss this finding in a case of a floppy baby. The presence of tongue fasciculation, a very important clinical finding. No protrusion of tongue or persistent tongue thrusting. Neck was normal. Chest, again a very important finding, appears bell-shaped with splaying of lower ribs. Bell-shaped chest with the splaying of lower ribs. In spinal muscular atrophy type 1, type 1 is Wernicke-Hoffmann, which is most severely affected. The pulmonary rib cage moves inward during the inspiration rather than outwards while the abdomen expands. So this is the inward movement of rib cage during the inspiration rather than the outward, which leads to atelectasis of the upper lobes of the lung and underdevelopment of the upper chest wall, and this results in bell-shaped chest. So there is a involvement of the intercostal muscles which are affected, and there is a movement of rib cage during inspiration inwards rather than the outwards, and this leads to atelectasis of the upper lobes of the lung. Look at this picture. This is a normal shaped chest, bilaterally symmetrical. And what is happening here? You can say the chest movement is inward during the inspiration. So this is the classical shape which has been described in spinal muscular atrophy, bell-shaped chest, splaying of ribs with intercostal weakness, intercostal muscle weakness leading to chest retractions. So this is, you can say, the cause of impending respiratory involvement or failure. Now coming to systemic examination, frog-leg posture, higher mental functions. So it is very important to be very clear in the case of floppy baby whether the central nervous system or the higher mental functions are affected or not. Because as we progress, we will say see the floppy baby is divided into two categories. One, where the cause is central, and second, the where the cause is peripheral. So we have to make it very clear from the history and examination whether the cause is central or not. So as in this higher mental functions, the baby is alert, interested in surroundings, no tonic posturing, no fisting, no vacant look. So all these things suggest there is no central cause of this floppiness in this child. Cranial nerve examination. First, we are not able to test. Second, able to fix and follow the bright objects. Light reflex was present for the third cranial nerve. Motor examination. So I will do the detailed cranial nerve examination later on. Bulk. Visibly wasted. So the child was looking visibly wasted. Muscles are soft and flabby. And this is important. There is a symmetrical wasting. Always say whether it is symmetrical wasting or an asymmetrical wasting. And when you can say this, when you take the measurements. When you take the measurements of the right arm versus left arm, right forearm versus left forearm, again mid thigh versus left mid thigh. If you take the measurements, then only you can say the wasting is symmetrical or asymmetrical. Coming to tone in this child. Floppiness of all four limbs plus. Tone symmetrically decreased in all four limbs. Now the important examination strategies in this child. Traction response. Look at this. Complete head leg present. In sitting position, complete curving of the back. So here the complete curving of the back with falling of head to either front or back. So the head is swaying, you can say in the front or the back, and there is complete curving of the back and there is no head control. When we pull the baby to sit, vertical suspension. Look at this. Baby slipping through the hands. No spontaneous kicking movements. No scissoring. So if there was a scissoring present, it would have suggested the central cause. So no spontaneous kicking movements suggesting floppiness. No scissoring suggesting the central cause. So one is traction response. Second is vertical suspension during the examination of this baby. Ventral suspension. Third strategy. When we do the ventral suspension of this child, so there is complete head drooping. There is a rag doll posture, means there is a very free movement at the joints, at the terminal joints, complete curvature of the trunk. So ventral suspension. Keeping the baby in prone position like this. No spontaneous attempts to lift the head. So there is no spontaneous attempts to lift the head, no pelvis lift or spontaneous flexing of the knees. So you can say traction response, vertical suspension, ventral suspension, prone position. So all these are very important examination tools in a small baby who is presented to you with the floppiness. So you have to describe these examination findings to the examiner. Power. Upper limb, look at this, shoulders and wrists. So here the power is less, here it is more. Again, there is a proximal weakness more as compared to distal. So again, this should be very clear from your examination finding. This was very evident in the history also, and now during the examination. The proximal weakness is more than the distal weakness. So this should be very clear. Then the palmar grasp was present but weak. Paradoxical chest movement during inspiration, respiration. This I've already told you, due to intercostal weakness. So what is the impression of these examination findings? It is symmetrical involvement. One, definite weakness of both upper and lower limbs, which is going in favor of proximal more than the distal. And the weakness is also involving the intercostal muscles, which is leading to respiratory distress and breathing difficulty with the sparing of diaphragm. So this is the impression of this. Now, a very important component of examination is neonatal reflexes. Since this is a 3 month child, we have to do the some reflexes which are very important. See, in this child, eliciting the knee jerk, ankle jerk, these reflexes are as important as eliciting the neonatal reflexes because this is a 3 months baby. Moro reflex, not elicitable. So this is very important. Rooting reflex intact, palmar grasp present but weak. Stepping reflex, not elicitable. Placing reflex, minimal flexion at the knees. Asymmetric tonic neck reflex could not be elicited. See, the neonatal reflexes, they are depressed or decreased if the baby is severely hypotonic. I repeat, the neonatal reflex may be depressed if the baby is severely hypotonic. Stepping reflex, there is no problem. Since this is a 3 months child, we expect the stepping reflex to disappear by this age. Placing reflex, again, may disappear by 3 months, no problem. Parmal grasp, again, may be present, may not be present. But the importance of this is Moro and asymmetric. Moro reflex can persist up to 6 months. It usually disappears by 3, but may persist up to 6 months. So if it is not eligible at 3 months, it may be that it is not present because of severe hypotonia. Asymmetric tonic neck reflex, again this is present till 6 months. Not present, again indicating severely hypotonic child. A few words about Moro reflex. So Viva can go to this reflex also. Any sudden movement of the neck initiates this reflex. How do you elicit? By pulling the baby halfway to the sitting position and suddenly let the head fall backwards. We suddenly let the head fall backwards by 45 degree. And what is Moro's? Consists of rapid abduction and extension of arms, one component, with opening of hand, second component, and then the arms come together as an embrace, third component. So this is called as complete Moro reflex. Suddenly let the head fall backwards. The baby shows rapid abduction and extension with opening and coming together of arms. So this is called as complete Moro. Significance of Moro. Just a few Viva questions. Absent Moro can be seen in CNS depression by narcotics or anesthesia, brain injury, hypoxia, or if there is a kernicterus, very premature babies. Similarly, severe hypotonia, the Moro may not be elicitable. Asymmetric Moro. Again, a very important Viva question. If there is an Erb's palsy, if there is a fracture of clavicle or humerus, and you can add one more, if there is a hemiparesis of one side, then also the Moro will be asymmetrical. And if the Moro is persisting beyond 6 months, it indicates CNS damage. So these are few words about Moro. Similarly, asymmetric tonic neck reflex. Again, a very important reflex. Limbs extend on the same body side to which the head is turned. So the head is turned towards this. These limbs are extended. So again, this side is showing extension. So this is called as asymmetric tonic neck reflex. Fully present at birth, and it is present till 6 months, active until 6 months of life. So in this baby, Moro and asymmetric tonic neck reflexes were not present, again indicating the presence of severe hypotonia. A few words about walking reflex or stepping reflex. When the sole of foot is pressed, the baby tries to walk. So there is a reciprocal flexion and extension of the limbs as if the child is walking, and the reflex may disappear by 2 to 4 months or even earlier by 6 weeks. So absent stepping or walking reflex is not important in this child. Placing reflex. So just I am telling you these reflexes, so you should know these reflexes can be asked during the Viva. Placing reflex. Bringing the anterior aspect of tibia against the edge of the table like this. So tibia is brought against the edge of the table. What is the response? The lifts leg on the table and again appears at birth and disappears by 6 to 10 weeks. Now coming to further continuing with the examination of this baby respiratory, we have done the CNS examination of this child respiratory system. bell-shaped chest, as I described earlier, with splaying of lower ribs, with due to intercostal weakness, increased work of breathing with tachypnea and mild intercostal retractions. Paradoxical movement of chest wall, again very important. Going in during respiration and abdomen moving out during inspiration. On auscultation, bilateral crepitations present. Now, examination of the mother, again very important. I told you there are few important conditions like myotonic dystrophy, like myasthenia gravis. So there was no ptosis was apparent in either of the parents. Grip myotonia or percussion myotonia seen in myotonic dystrophy. So the babies born to mothers who are suffering from myotonic dystrophy may present with congenital myotonic dystrophy. So there was no myotonia or percussion myotonia in the mothers. There was no myopathic phases in the parents. So this examination, a few words you have also to describe. Also, you have to keep a watch on the parents' face, myopathic phases or myotonia. Now, how will you summarize this case presentation? 3 months child born to non-consanguineous parents with a significant antenatal history of decreased fetal movements. So what is its importance? It is clearly indicating that the disease has its onset during the intrauterine life. With an uneventful natal history, with a smooth transition into the postnatal period, with history of generalized and symmetric. So every word has its importance. It has a generalized and a symmetric paucity of movements of limbs and neck. I told you in the history there was limited neck movements. So there was decreased movements of limbs and the neck, generalized floppiness with a weak cry and prolonged sucking, all of which have been noticed since the last 2 months, with worsening of feeding difficulties and respiratory distress for last 15 days. So this is the summary of the history, with not gaining weight or failure to thrive, and with delay in the gross motor milestones, but preservation of social language and visual milestones. So you can say delay in the gross motor milestones. The head control is not achieved by the baby. So this is the complete summary in the history. Examination, further going with the summary. The child shows on examination failure to thrive, weight for length less than 3 standard deviation, with no facial dysmorphism, with an intact sensorium, with severe hypotonia and symmetric weakness of the limbs, which is more proximal as compared to distal. Floppy baby, with intercostal weakness and preserved diaphragmatic tone, along with areflexia and significant tongue fasciculations. I told you, you cannot miss this history and examination and tongue fasciculations. Other system examinations revealed a stable cardiac status with an abnormal bell-shaped chest wall, with the child showing respiratory distress and paradoxical breathing movements requiring oxygen support. So you see every word, every finding, every history is carrying the importance from the very beginning. Symmetric weakness, generalized weakness, more proximal as compared to distal, limited neckway movements, gross motor delay, important examination findings with tongue fasciculation and areflexia and failure to thrive, with bell-shaped chest. Everything, every word, every finding is carrying its importance since beginning. What is your diagnosis? Floppy baby or floppy infant with generalized hypotonia. I repeat, it is a generalized hypotonia. Peripheral. I told you there is no central cause by the history. On history, the child sensorium was normal, child was alert, interacting with mother, responding with the mother, higher mental functions seem to be okay. So the cause is likely to be peripheral and predominantly proximal versus more weakness as compared to distal with fasciculations in the tongue. Likely to be disorder of anterior horn cell. Most likely spinal muscular atrophy type 1 or early infantile type or Wernicke-Hoffman disease, which has started very early in the life with the complications of not gaining weight and aspiration pneumonitis. So this is your complete diagnosis by history and examination. Now we come back to floppy baby a little later. Just how to go for a CNS examination. So everyone of us, every one of you is likely to get two cases in the exam, four ward rounds, and you can say out of these, one or more is likely to be definitely a CNS case. So you should be very thorough with the CNS and cardiac cases especially. And I have told in my previous classes also that your format should be a correct. You should at least you should know the definite headings. You should remember the headings and you should say the history and examination in these headings only. So just this is you can say important headings in the CNS examination. How you should go with these? You should go in these sequence. First of all, higher mental functions you should comment. Second in sequence, cranial nerves. Third in sequence, motor examination. Important motor components, bulk, tone, power, and reflexes. And fifth is gait. So this is the complete motor examination. Then the sensory examination, cerebellar signs, signs of meningeal irritation, and in the last comment on the skull and the spine. So be thorough with this sequence. If you know the sequence, if you know the headings, then automatically you will do the examination and comment under these headings. So few words about the level of consciousness. So I will start with here lethargic. What is a lethargic child? Child sleeps a lot, but he can be easily aroused with minimal stimulus. So the baby can be aroused with minimal stimulus like voice. Obtundation. Child can be aroused by stimulus which is short of a painful stimulus. That is just by shaking, and then the child will respond to pushes. So now here the severity increases in this pattern. The level of consciousness you can say decreases in this pattern. Stuporous child, condition of deep sleep or unresponsiveness. And here the child can be aroused only by painful stimulus. And comatose, there is no motor response to the external environment, even a deep painful stimulus is applied. So these are few words or you can say terminologies you should know while describing the level of consciousness. Now you should have some idea about this Glasgow Coma Scale. Three important components: eye opening, verbal response, and motor response. So three important components: eye opening you can say score of 4, verbal response total score of 5, motor response total response of 6. So three components: eye opening, verbal response, motor response. If possible, try to classify under these headings. And you can say a patients with score of less than or equal to 8, they require aggressive management. So Glasgow Coma score of less than or equal to 8, they require aggressive management. Another score which has been described, you can say 4 score. Now in this, eye opening is same, motor response is same, but verbal response is out. What we have added? Brain stem reflexes and respiration. So 4 components: eye response, motor response, brain stem reflexes, and respiration. Verbal response is taken out. What is the advantage, or you can say comparison? So as you say, eye, motor, verbal in Glasgow Coma score, 4 score you have eye, motor, brainstem, and respiratory pattern. Glasgow Coma scale, it has a limited utility in intubated patients, but it can be used even for testing for intubation patients and with brainstem reflexes. So this is the comparison between these two scores. Now speech, a very important component of higher mental functions, higher component examination is speech. You have always you have to comment on the speech. Speech indirectly indicates the higher mental functions. So remember some important things. There are three important areas: Broca's area, motor cortex, arcuate fasciculus, and Wernicke's area. So what is the importance of Broca's area? It is involved in the production of speech. So Broca's area is involved in the production of speech. Second second area, Wernicke's area. It is involved in the understanding, or you can say comprehension. So Wernicke's area की क्या importance है? Comprehension में. Broca's की क्या importance है? Output निकालने में, बोलने में, और expression में. So Wernicke's area is important in expression or speech output. Sorry, Broca's area is important in speech expression or output. Wernicke's area is important for comprehension. Then the motor cortex control the movement of muscles, and arcuate fasciculus, this connects the Broca's versus Wernicke's. So a simplified model, this is Broca's area, which is helpful in the expression or speech output. Then Wernicke's area, which is important for registration or comprehension. Arcuate fasciculus is involved in repetitions of words. So types of aphasia, there are other types of aphasia also, but you can say these are the four important types of aphasia you should know. Broca's, मैंने बताया था Broca's की importance कहाँ है? Output में, expression में. So Broca's aphasia will be speech abnormal, repetition abnormal, finding words or naming words impaired. But what is preserved in Broca's? Comprehension. So in Broca's aphasia, comprehension is intact, rest all are impaired. Wernicke's area किस लिए होता है? Comprehension के लिए. So in Wernicke's area, repetition is impaired, comprehension is impaired, naming is impaired, but speech output or fluency is preserved in Wernicke's aphasia because this part is controlled by Broca's area. Conduction aphasia में arcuate fasciculus involved हो रहा है, तो fluency भी intact है, comprehension भी intact है. What is impaired? Repetition and naming. So conduction aphasia में comprehension and speech output is normal. Global, everything is abnormal. So you have to describe the speech. You should know about speech. This is a very important component of higher mental functions. So Broca's aphasia, Wernicke's aphasia, conduction aphasia, and global aphasia. You need to have some idea about these different types of aphasia. Can sometimes also be asked in the OSCE based questions. Dysarthria, defect in the articulation. It is the defect in the articulation. So flaccid type seen in bulbar palsy or lower motor neuron. And what is the pattern? Hypernasality or the nasal character. So flaccid dysarthria seen in bulbar palsy or lower motor neuron lesion. Spastic dysarthria seen in pseudobulbar or upper motor neuron type of lesions. Very imprecise articulation. Ataxic type seen in lesions of cerebellum. Hypokinetic type seen in Parkinsonism or in extrapyramidal involvement. Hyperkinetic type again can be seen in extrapyramidal type of lesion. So you should know the types of dysarthria, and if there is any dysarthria, you need to comment on what type of dysarthria it is there or defect in articulation. What is the difference between the bulbar palsy and pseudobulbar palsy? So as I told you, bulbar palsy, it is a lower motor neuron lesion affecting the cranial nerve 7 to 12, and this leads to flaccid paralysis of pharynx and larynx. So this is the bulbar area. This is the bulbar palsy. Pseudobulbar above the nuclei. So this is the pseudobulbar area above the nuclei. a bilateral upper motor neuron disorder. Bilateral upper motor neuron disorder leading to spastic. So these words are again very important. Here the paralysis is flaccid. Here the paralysis is spastic of pharynx and larynx. So just a comparison between pseudobulbar versus bulbar. So pseudobulbar is a upper motor neuron. So the reflexes are increased. Gag reflex increased in pseudobulbar, absent in bulbar palsy. Tongue spastic, wasted in bulbar, or it may show fasciculations. Jaws are exaggerated in pseudobulbar, may be normal in bulbar or absent. Speech spastic dysarthria in pseudobulbar, nasal variety of speech in bulbar palsy. UMN signs in pseudobulbar palsy, lower motor neuron signs in bulbar palsy. Labile emotions, here it is normal in bulbar. And important causes, you can say bilateral cerebrovascular accidents, multiple sclerosis, motor neuron disease. In bulbar, Guillain-Barré, poliomyelitis, motor neuron and brainstem infection. So these are the clear-cut differences between pseudobulbar versus bulbar palsy. Now, this was I described the higher mental functions. The first in the sequence. Second in CNS is the cranial nerve. So why this I have shown the table to you? Just to highlight three important things. Number one, cranial nerve number one, olfactory, cranial nerve 2, optic, and cranial nerve 8, auditory. So these nerves are purely sensory in nature. Then cranial nerve 3, oculomotor, cranial nerve 4, trochlear, then cranial nerve 11, cranial nerve 6, abducens, 11, spinal accessory, cranial nerve 12, hypoglossal. These are purely motor nerves. And Bachiwi, you can say 5th, 7th, 9th, 10th have both sensory and motor component. So whenever you are doing the cranial nerve examination, remember these things in the mind, which is pure sensory nerve, which is pure motor nerve, and which nerve is both sensory and motor. Because in sensory and motor, you sometimes need to test both sensory and motor domains. So that is the importance of this table, which is pure sensory, which is pure motor, and a mixed nerve. Now, olfactory you are not able to test most of the times. Coming to the cranial nerve 2. How do you test cranial nerve 2? What are the modalities? By eye charts, visual fields, pupillary light reflex. But light reflex is also a component of oculomotor. So in optic nerve impairment, we can have blindness and loss of pupillary constriction. But most of the times, the patients we get in our exams, they are generally, you can say, are not cooperative, or you can say they have central component of illness or like TBM type. So most of the time we have to resort to this fundus examination. So always carry an ophthalmoscope with yourself in the exam. Always try to do fundus examination. Always try to have this tendency to carry the ophthalmoscope and do the fundus examination. This will help in the testing of cranial nerve 2. So this is a very important finding. Many times you get an OSCE based questions on the fundus. So this picture is showing you the optic nerve involvement. So this is the normal optic nerve. And here what you are seeing, the normal optic nerve head appears yellow to orange like this, while an atrophic optic nerve appears pale. So this is clearly pale, or you can say whiteness. So this is clearly suggestive of optic atrophy. So always try to look at the fundus. At least when the examiner asks you, have you done the fundus? Always say yes. Because if you have done, then you can always say, yes, I have tried. Then the cranial nerve 3, 4, and 6. Oculomotor, third nerve. What are the findings in the third nerve? Complete ptosis. So ptosis as it is apparent. Eye is down and out, and pupils are dilated. They are not responsive to light and evaporation. So this is the third cranial nerve. Ptosis, down and out eyes and dilated pupils. Light reflex is no there, not there. Proclear, fourth nerve. Double vision going downstairs. Ask the patient to turn eye and then look down. It may cause vertical hypertropia. So it will again come in the next slide. Sixth nerve, failure of lateral movement. So you can say failure of lateral movement or medial strabismus. Fourth nerve originates in the midbrain, supplies to superior oblique muscle of the eye. Proclear nerve supplies the superior oblique muscle of the eye. So what is the important finding? This is normal, and in the affected side, there is outward rotation of the affected eye. There is an outward rotation of affected eye, and also the patient complains of vertical diplopia. So this is a very important finding, outward rotation of affected eye. So third, fourth, and sixth cranial nerve. Ptosis, mydriasis, eye down and out in the third cranial nerve, as I have already told you. Fourth cranial nerve, lesions of the right trochlear nerve, the eye is outwardly rotated and upwards. So affected eye drifts up and extorts, as is seen here. Individuals with the trochlear nerve lesion, they compensate for this by tilting their head forwards and to the side opposite to the lesion. So there is a head tilt towards the opposite side or towards the left side, as is apparent from the picture. So the eye drifts up and extorts out, and this is the medial strabismus. So these are the lesions of the third, fourth, and sixth cranial nerve. I hope this is very clear to you. Fifth nerve. So this is a mixed nerve. Ask the patient to clench the teeth and palpate the temporal and masseter muscles. Pain, temperature, touch can be tested over these divisions. And what are the important reflexes? Corneal reflex and the jaw jerk. Corneal and the jaw jerk. So testing the trigeminal nerve by two reflexes. First is jaw jerk. So I've shown in the picture. Ask the patient to relax the jaw. Place the finger on the chin here and tap it with the hammer. What is the normal response? Closing of the mouth. This is the normal response. And normally the reflex is present. Or you can say little bit this. But if it is exaggerated, then it is pathological. Then the reflex is pathological, exaggerated reflex. Corneal reflex. As in the picture, the cornea is touched with the wisp of wet cotton. Response is closing of both the eyes. What is the afferent? Ophthalmic division of fifth nerve. Ophthalmic division of fifth nerve. And efferent is facial. So again the corneal reflex. Afferent, sensory arc of cranial nerve fifth. So you can say trigeminal is sensory here and facial is the efferent arc. Instruct the patient to look up, approaching the patient laterally out of his line of vision and avoiding the eyelashes. Touch the cornea with a fine wisp of water. So the procedure I have described you, and what is the normal reaction? Blinking of the eyes. So important thing is, remember to this is afferent is fifth and motor is facial in corneal reflex test. This is how we test the corneal reflex. Then the seventh cranial nerve, motor function. Ask the patient to smile, frown, close eyes tightly. Motor component. Facial muscles intact and symmetrical, as looking in this photograph. Sensory function, it is not tested routinely. Test only if we have suspected facial nerve injury. Taste on anterior 2/3 of the tongue. This is the sensory way, or you can say sensory testing. Apply to the tongue solution of sugar, salt, or lemon juice. If patient to identify correctly, then the sensory function is intact. 9th and 10th, they are tested in together. Motor function, swallowing. If it is intact, then likely to be intact. Depress with the tongue and note the pharyngeal movement. movements only can be done if the patient is cooperative and as the patient says ow. Position of uvula rises midline with phonation. So again the uvula is in midline on saying ah. Then touch the posterior pharyngeal wall for gag reflex. If the gag reflex is intact, then the nerves are intact. Sensory, generally not tested because we have to test the taste on the posterior 1/3, which is not routinely done. So this was broadly the cranial nerve examination. Now coming to assessment of tone, grading of the tone. So this is the modified Ashworth scale for assessing the tone. Scale 0, there is no increase in muscle tone. 1, only slight increase in the tone. And when we check for the tone, it is manifested by catch and release or a minimal resistance. We find minimal resistance at the end of the range of motion. Like you can say this is the range of motion, this is the midway. So only in the terminal part we find the resistance at the end of range of motion. Then 1 plus, I am not going in detail. Then the grade 2, more marked increase in muscle tone and through the most of the range of the motion. So 2 is usually throughout the range of the motion we find the resistance. Grade 3, considerable increase in muscle tone and we find the passive movements difficult. And grade 4, the part affected is rigid in flexion and extension. So you should have some idea about this grading of the tone. 0 is no increase, grade 1 is slight increase, only the end of the range of the motion is affected. Grade 2, marked increase and through the range of the motion. Grade 3, considerable increase, passive movements difficult. And grade 4, the part is rigid in flexion and extension. Then grading of power. So this is MRC grading. Medical Research Council scale for power of muscles. So always tell what is the power. Grade 0, there is no response. No flicker, no contraction visible. Grade 1, flicker of contraction, but there is no movement. 2, the movements occur when the effect of gravity is eliminated. 3, movements against the gravity. So there are movements against the gravity, but not against the examiner's resistance. 4, movements are present against resistance, but it is weaker than the normal. And grade 5, it is a normal power. So always these are small, very basic things. But sometimes, as I told you in the exams, the candidate sometimes flunks at the basics. So always grade the power 2, 3, 4 and never do the wrong grading of the muscles power. Now coming to the reflexes. Again, a very important component of the motor examination. So first and foremost, what is the root value of knee jerk? Some books say L2, L3, L4. Some say L3, L4. Idea is L3, L4 is you have to include. L2 may or may not include it, but L3, L4 is definitely to be included. Now, what are the key points? Flex the knee and place the forearm under the knee to be tested. Sometimes examiner tells you to do the jerk in the front of this view himself. So when he asks you, he notice these things, whether you are giving a support or no. So place the forearm under the knee to be tested. Strike the patellar tendon midway. And what do you look for? Extension of the knee and contraction of quadriceps. So extension of the knee or contraction of quadriceps. So this is how we do the knee jerk. So always support the knee by placing the forearm under the knee to be tested. Ankle jerk. So important root value S1. So what is the posture? Hip externally rotated, slight flexion of the knee, dorsiflex the ankle so as to stretch the Achilles tendon and strike the tendon on the posterior surface. So hip externally rotated, slight flexion of the knee, ankle dorsiflex and striking on the posterior surface. So what do you look for? The plantar flexion of the foot can be felt by the hand of the examiner. So plantar flexion of the foot can be felt by the hand of the examiner. Again, root value you have to remember S1. Triceps C7, C8. So how do you do? Position patient with the arm across the abdomen with elbow flexed, strike the triceps tendon. And this crosses, you have to look here. Look for the elbow extension or contraction of muscle belly. Look for the contraction of muscle belly or look for the elbow extension. Again, a very important reflex, Babinski reflex. Stroke the lateral aspect of the sole of the patient's foot with your thumbnail or moderately sharp object. So what is the normal response? This elicits flexion of all toes. Now here the reflex is negative, or you can say a normal response. When the reflex is positive or a positive Babinski, the great toe dorsiflex and the other toes fan out as shown in the illustration. So this is a normal toe, this is a positive Babinski reflex. So again, normal response, positive response, the dorsiflexion of the big toe. Now the root values. Always try to remember these root values. Questions have been asked on these root values in the past. Knee reflex, L3, L4. Some books say L2, L3, L4 also. Biceps, C5, C6. Brachioradialis, C5, C6. Triceps jerk, C7, C8. Ankle jerk, S1, S2. So always include S1. Jaw jerk. Cranial nerve, 5th. Jaw jerk, cranial nerve, 5th. So these are the root values of some important deep tendon reflexes. Neck signs. So you always have to comment on the CNS examination in a single line. Are there any signs of meningeal irritation or no? Kernick sign. How do you elicit? Resistance to extension of the leg when the hip is flexed. So this is Kernick sign. Brudzinski sign. Flexion of the hips and knees. So there is a flexion of the hips, flexion of the knees in response to neck flexion. So this is a Brudzinski sign. Make a one-line statement. There are no signs of meningeal irritation. So we have done the history examination, we have done the cranial nerve examination approach and cranial nerve examination in detail. Now coming back to floppy baby. Your Viva can go on what is the differential diagnosis, what is your investigative approach, and your Viva can go on some theoretical topics also. So what do you mean by floppy? Floppy simply means decrease in muscle tone, hypotonia or decrease in muscle power weakness. But strictly speaking, floppy refers to hypotonia. Floppy refers to hypotonia. What are the useful indicators of weakness? Poor swallowing ability, as indicated by drooling and oropharyngeal pooling of secretions. What is important? Character of cry. So in our case, the baby had weak cry since birth. Infants with consistent respiratory weakness, they have a weak cry. So weak cry, indicator of weakness. Poor swallowing ability, indicator of weakness. Paradoxical breathing pattern. Intercostal muscles paralyzed. So these are some important indicators of weakness. How do you classify the causes of floppy baby? So cause number 1, central cause, CNS causes. Perinatal asphyxia, neonatal encephalopathy, kernicterus, cerebral palsy, intracranial hemorrhage, chromosomal abnormalities like Down syndrome, inborn errors of metabolism like mucopolysaccharidosis, then spinal cord lesions, Differential number 2, spinal cord lesions like anterior horn cell disease. Under this comes your important Wernicke-Hoffmann disease and SMA, a very important topic. Peripheral nervous component includes acute polyneuropathy, familial dysautonomia. Then fourth, myoneural junction. In this important component, neonatal myasthenia gravis or infantile botulism. Fifth, muscular component or defect at the level of muscles. Important causes muscular dystrophies, congenital myotonic dystrophy, as I told you earlier, congenital myopathies, polymyositis, glycogen storage disorders like Pompe's, arthrogryposis multiplex congenita, and then the miscellaneous causes like protein energy malnutrition, rickets, Prader-Willi syndrome, malabsorption syndromes, Ehlers-Danlos syndrome. So these are the different headings under which you classify floppy baby. So if the examiner asks you what is your differential diagnosis, so try to list the causes under these important headings. So this is a pictorial of the same which I have told you. The central causes: chromosomal disorders, metabolic disorders, spinal cord injuries, cerebral dysgenesis, HIE. Then motor neuron, spinal muscular atrophy. Then peripheral nervous causes. Then neuromuscular junction, congenital myasthenia infantile botulism. Then muscular causes, muscular dystrophies, myopathies, central core disease, other congenital myopathies. So this is just a pictorial of what I have told you earlier. Again, same picture pictorial, central causes in the CNS, then the anterior horn cells. Here the SMA fits or Wernicke-Hoffmann, then the peripheral nervous causes, then the neuromuscular junction causes, and then this muscular causes. So these are again under 6 headings which I have described you, the causes of hypotonia. Now what is your approach? What are the important things you should always ask? I have already told you in the history, this is just a short repetition. The presenting complaints can be regarding the tone, difficulty in feeding, weak cry, decreased movements, delayed motor milestones, and complications of muscle weakness like respiratory infections or respiratory distress. These are the things you should ask in the complaints. Then the age of onset of the disease. Like type 1, I told you they present very early. Type 2, they present generally after 6 months. Type 3, they generally present after 12 months. So what is the timing of onset of the disease? Neonatal myasthenia, it also presents soon after birth. So timing of onset of disease also to be ascertained in the history. Then if it is whether it was a sudden onset like intraventricular hemorrhage in premature babies, what is the course of illness? Static, progressive, fluctuating. A very important thing in the history, distribution, proximal versus distal. I already told you whether there is an associated atrophy of the muscles, other history of any muscular pains. So if there is a older child, you can also ask this history of muscle pains, history of any joint deformities which can be seen in Zellweger, arthrogryposis, congenital muscular dystrophies, myotonic dystrophies, history of any joint deformities, congenital dislocation of hip, also seen in muscular dystrophies. Then history is related to CNS cause, whether history of any seizures, mental retardation, poor state of alertness, lack of response to visual and auditory stimuli, any dysmorphic features. So all these things are important for the CNS cause. Any dysmorphic features, like in cerebral dysgenesis, Zellweger syndrome, Prader-Willi syndrome, severity of illness, any respiratory difficulty, history of fatigue on continuous sicking, like in which can be seen in neonatal myasthenia, history of constipation, a very important feature in infantile botulism. Now, what are the important findings in the examination? decrease resistance of joints to a passive movement, increase in the range of movements of joints, decrease spontaneous movements. So all these things you have to comment on. Like I have already told in that previous case. Physical examination. It can be divided into decreased strength leading to poor head control. So in this there is showing the poor head control. 1. The baby has weak cry, poor sucking, lack of facial expressions, decreased spontaneous movements, and decreased respiratory efforts. All these are the important findings in the physical examination of the floppy baby. I have just tried to show you by the pictorial. Then, if we are looking at the dysmorphic features, if there are dysmorphic features, then there can be some syndromes. Syndromic baby, then floppy newborn, history of uterine dystonia in the mother during labor, history of uterine dystonia in the mother during labor, difficult delivery, then history of myotonia in the mother. I told you, myotonia in the mother. Then suspect congenital myotonic dystrophy. So all these are important in the evaluation of the floppy baby. Now this is a vertical suspension. This is the normal response and this is the abnormal response. Slipping away. This is the abnormal response to vertical suspension. All these by pictorial so that you can remember easily. Then what are the clues for central hypotonia? So I told you hypotonia can be central, it can be peripheral. Central hypotonia, the features are depressed level of consciousness. तो बेबी का कॉन्शियसनेस लेवल कम हो सकता है, डिसमॉर्फिक फीचर्स हो सकते हैं, फेशियल फीचर्स, फेशियल जेस्चर्स अफेक्टेड हो सकते हैं. It is a predominantly axial weakness, abnormal development, and reflexes can be brisk. So these are the features suggesting central hypotonia, and features suggesting peripheral hypotonia. The baby will be alert. Poor feeding may be there, respiration may be affected, distal involvement may be more, profound weakness, and absent reflexes and fasciculations present. So this is the flowchart which shows the differentiating features of central versus peripheral hypotonia. Again, this I have told you earlier. The frog leg posture, significant head lag on traction or pull to sit maneuver, ragdoll posture, vertical suspension. So you can be asked sometimes to do these things in the front of the examiner. Like this is the ragdoll phenomena, the shaking the limbs and observing the movements at the distal joint. In hypotonia, the movements at the joints are increased. This is the frog leg posture, which I was talking about. Then this is the traction response. This already I have told you. Now, certain other important maneuvers for hypotonia. First, popliteal angle. Popliteal angle. So it is an assessment of tone. So popliteal angle. It is an assessment of the it is an assessment of tone of hamstring muscles. It is done one leg at a time. The thigh is flexed on the abdomen with one hand, and then the other hand straightens the leg back, pushing on the back of the ankle until there is a firm resistance to the movement. What is the normal angle? You can say 80 to 90 degree. This is the normal popliteal angle in a term baby. Extension of the leg beyond 90 to 120 would be seen in hypotonia. So this is, you can see, it is measured by flexing the thigh against the abdomen and extending the lower leg to the point of resistance. So here you can say the normal popliteal angle is around 80 to 90 degree. But if it is more than 90 degree, it can be seen in hypotonic babies or in preterm babies. Hypotonic babies or preterm babies. So this is how your popliteal angle is also one assessment of the tone of the baby. Scarf sign. Put the child in a supine position and hold one of the infant's hands. Try to put it around the neck as far as possible around the opposite shoulder like shown in the picture. Observe how far the elbow goes across the body. In a floppy infant, the elbow easily crosses the midline. So elbow easily crosses the midline in a floppy baby. So this is also one method of assessment of tone in the babies. Arm recoil. Arm recoil. This arm recoil tests tone and power of the biceps. The arms are held in flexion against the chest for a few seconds, then quickly extended and released. The arm should spring back to the flexed posture. So this is the normal arm recoil, and if the tone is okay, tone is normal, we will see the full arm recoil. But in hypotonic babies, it will show an incomplete recoil. So these are also some maneuvers which you can say, which can be asked by the examiners to demonstrate, which are also useful in the assessment of the tone in small babies. Initial approach to the floppy infant is to determine whether it is central or peripheral. I told you earlier. Now differentiating clinically. Floppy strong, floppy weak. Increased tendon reflexes, extensor plantar, sustained clonus, global developmental delay, microcephaly, obtundation, convulsion, and predominantly axial weakness. These are seen in floppy baby with central cause. Floppy peripheral or floppy weak. Hypo or areflexia, selective motor delay, normal head circumference, preserved social interaction, weakness of anti-gravitational limb muscles, low-pitched weak cry, tongue fasciculations, paradoxical chest wall movement. I hope this slide tells you everything in detail, how to differentiate the central causes of floppy versus peripheral causes of floppy baby. Floppy strong. Now, what are the investigations? How should you go for investigation? Floppy strong, upper motor neuron you suspect or central cause. Then you can go for genetic studies, karyotyping, fish analysis, or very long chain fatty acid analysis. For these can be done for conditions like Down syndrome, Prader-Willi, or Zellweger syndrome. Neuroimaging can be done for HIE or cerebral malformations. Floppy weak, lower motor neuron lesions, peripheral hypotonia present, important investigation, CPK, EMG, nerve conduction velocity. So these are some important investigations in peripheral causes of floppy baby. Then DNA based analysis can be done in spinal muscular atrophy, SMA, congenital myotonic dystrophy, congenital muscular dystrophy, DNA based analysis. Muscle biopsy can be done in congenital structural myopathies or nerve biopsy. Now, differentiating features of a floppy baby according to the cause and according to the site of the involvement. So, if you look at this, if there is a central cause, The proximal weakness will be more than the distal, but the face is generally not affected. Arms and legs are symmetrically affected. Proximal is slightly more or maybe equal to distal. Anterior horn cell is the site of involvement. Face may or may not be affected. Arms and legs are symmetrically and proximal more than distal. Peripheral nerve. Here the distal is more than the proximal. Face is not affected. Neuromuscular junction. Face is predominantly affected, like in myasthenia gravis. Arms and legs are symmetrically inverted. Proximal is equal to distal. Muscles, variable. But in muscle involvement, proximal involvement is more than distal. Deep tendon reflexes. In central cause, it may be increased. Anterior horn cell reflexes absent. EMG shows fasciculations. Muscle biopsy shows denervation pattern. Peripheral nerve is the cause, reflexes decreased. EMG shows fibrillation. Muscle biopsy shows denervation pattern. Neuromuscular junction like myasthenia. A very important feature, decremental response on EMG. Decremental response on EMG. Deep tendon reflexes, normal. Muscle reflexes may be decreased. EMG shows short duration amplitude potentials. Muscle biopsy is characteristic. So these are the different causes with their different features and investigations. So this all I have told you: hypotonia origin, twisting of hands, wrist reflexes, features of pseudoverbal palsy, features suggestive of HIE, seizures may be present. So this all I have told you: hypotonia of central origin. Now some common causes of floppy infant. In the end of this list, I will told you SMA in detail. So some common causes: cerebral palsy, number 1. So hypotonic cerebral palsy, it is a known entity, and in hypotonic cerebral palsy, the reflexes are brisk in spite of generalized flaccidity. So reflexes are brisk in hypotonic CP. So floppy infant due to cerebral palsy is associated with the baby is lethargic, shows poor feeding, lack of alertness, poor morose, and history of seizures during the neonatal period. Congenital myopathies. Second group, congenital myopathies. So these are rare conditions. These are inherited disorders. Result in benign congenital hypotonia with generally a good outlook. So it is a very broad classification which includes some important conditions like Niemelin myopathy. I will show you in the list. So this includes Niemelin myopathy, central core disease, centronuclear, fiber type disproportion, multiminicore. So you should know only the names of these conditions. It is very unlikely that examiner will go in the minute details. You should know only the differential diagnosis that one is congenital myopathies, and these are the conditions which are included in the congenital myopathies. Third is, again, these are congenital myopathies, central core disease, Niemelin myopathies. What are the clinical features? Progressive muscle weakness, proximal more than the distal, hypotonia, delayed milestones, skeletal deformities. And these conditions generally no specific treatment. So, not to go in the details of these congenital myopathies. Third condition, congenital myotonic dystrophy, seen in the floppy babies. So these babies are born to mothers with myotonic dystrophy. These babies are born to mothers with myotonic dystrophy. These babies show respiratory and swallowing difficulties. Moderate to severe intellectual disability may be present. But normally in myotonic dystrophy, we find myotonia. But in neonates, myotonia is absent. In neonatal myotonic dystrophy, myotonia is absent in these babies. So what else in myotonic dystrophy congenital variety? There may be history of decreased fetal movements. Like in our case, there may be history of polyhydramnios, generalized hypotonia, multiple joint contractures, significant facial diplegia, and respiratory inefficiency. So these are the babies with congenital myotonic dystrophy. Fourth heading, fourth cause of floppy baby, congenital muscular dystrophy. These are genetically heterogeneous group of disorders. They present at birth as floppy infants and they experience impaired motor and cognitive development. And what is important in this? The degree of CNS involvement. These patients show also brain malformations. These patients also show brain malformations. So the degree of CNS involvements tend to determine the overall clinical severity. So this was the fourth group of floppy baby. Then the fifth group, fifth important cause of floppy baby, congenital myasthenic syndromes. So the congenital myasthenic babies, they also present in the neonatal period with hypotonia. So usually autosomal recessive condition, and you can say in this condition shows the genetic disorders of acetylcholine receptors. Genetic disorder of acetylcholine receptors. In congenital myasthenic syndromes, the antibodies are usually not seen, so it is a separate entity from myasthenia gravis. The etiology is separate. And the last and the sixth most important group of floppy baby is spinal muscular atrophy. A very important OSCE based question and a very important Viva question. So this is the motor neuron as shown in the picture. So what happens in the spinal muscular atrophy? There is a degeneration of spinal and lower brainstem neurons. So look at this picture. This neuron is degenerated or this neuron is affected. As a result, this pathway is affected. So this transmission is affected, leading to atrophy of the muscles. So the degeneration of lower brainstem motor neurons. So here in this is affected or degenerated as shown in the picture. Now coming to genetics. What is the genetics of spinal muscular atrophy? Normally SMN1 gene present on the chromosome 5. SMN1 gene present on the chromosomal 5. So this codes for normal spinal SMN protein levels. So this is the normal phenomena. And SMN2 gene also present. This codes for low SMN protein levels. So normally also under normal circumstances also in a normal human being also this SMN2 gene codes for low SMN protein levels. As shown in this picture, this is the SMN2 gene and this is giving rise only to 10% functional SMN protein. 10% functional SMN protein and 90% non-functional SMN protein. This is the normal phenomena in a normal human beings. But what happens? There is a in pathophysiology, or you can say in the pathogenesis of SMA, there is a deletion of survival motor neuron SMN1 gene on chromosome 5. So SMN1 gene, this is affected on chromosome 5 in SMA. So the severity of disease is determined by the number of copies of SMN2 gene. Multiple copies of SMN2 gene allow for the production of SMN proteins, reducing the disease severity. So what happens? The severity of the disease is determined by the number of copies of SMN2 gene. If the copies of SMN2 gene are more, probably the disease severity is less. If the number of copies of SMN2 gene are less, probably the disease severity is high. So this is the classification of SMA. Type 0. Onset prenatal. So usually death in children less than 1 month. And look at this. SMN2 copies. Only one copy of SMN2 gene is there. So this is the most severe variety. Type 1 or Wernicke-Hoffmann disease. Onset 0 to 6 months. तो ऐसा कहा जाता है टाइप 1 बेबीज they are never able to sit. They may not achieve head control and they are never able to sit. and they usually die within less than 6 months. Look at this, SMN2 gene copies, 1 or 2. Type 2 SMA, presentation, onset 7 to 18 months. They can sit, but they cannot stand. They can survive up to 2 years or even more than 2 years. And look at this, SMN2 copies, 3 SMN2 copies. Type 4, benign variety, also called as Kugelberg-Villander disease. Presentation, after 18 months. They can also stand, they can also walk. And SMN2 copies, 3 or 4. And they can even survive into adulthood. And type 4, it is the most benign. Presentation after 21 years, they can stand, they can walk, they can survive well into the adulthood. 4 or more copies of SMN2 gene. So you can say more or the copies of SMN2, probably lesser is the severity of the disease of SMA. So the new sinersen, this has been the drug which has been approved for SMA, given intrathecally. Now coming to the clinical case-based scenario of SMA, a 4-month child brought with the delayed developmental milestones. Clinically, the child is alert, interacting with the examiner and the mother. So it means higher mental functions are preserved. Neurological examination shows the infant to be floppy with generalized hypotonia affecting the trunk and the limbs. Deep tendon jerks are not elicited and there is CTV of the left foot, fasciculations are noted. So what is the most likely diagnosis? Name 2 definitive diagnostic tests. What is the mode of inheritance? Give 4 subtypes of this diagnosis. So spinal muscular atrophy, so onset is very early, type 1 or Wernicke-Hoffmann disease. Important investigations. The first and foremost, the genetic analysis for SMN1 gene on chromosome 5. Electromyography will show fasciculations. And probably the last in the importance, muscle biopsy. Autosomal recessive inheritance, 4 types. Type 1, severe infantile form. Type 2, late infantile form. Type 3, chronic form, Kugelberg-Villander disease. I am type 0, severe fetal form, which is usually lethal in utero. Now, look at this genetics. In a normal human being, this SMN gene 1 codes for 100 functional SMN protein and SMN2 codes for only 10% of SMN proteins. But in SMA, SMN1 is totally affected. So this is lost. Now SMN2 is coding only for 10% of functional SMN protein. And this leads to the presentation of or classical picture of SMA. So patients with spinal muscular atrophy treatments. So this pictorial is showing the SMA treatments. So what is happening? This SMN1 gene, this can be expressed by this zolzanesma. This uses a harmless virus to deliver the normal copy of SMN1 gene. So this zolzanesma acts on SMN1 gene. I told you SMN2 gene normally codes for non-functional protein, but the drug Spinraza or Evrysdi, if these 2 drugs are given, they act on the SMN2 gene and then they code for functional SMN2 protein, and this compensates for the disease severity, or you can say this decreases the disease severity. So the current therapies approved by FDA for the treatment, nusinersen first. So I told you acts on the SMN2 gene, and what happens? It helps the SMN2 to make more of functional SMN protein. Indicated population infants to adults, given intrathecally, and but expensive. Then second drug, risdiplam. This again acts on the SMN2 gene and helps to make more of functional SMN2 protein. Targeted population more than 2 months. Systemic delivery, simple oral administration, but with side effects. Third, onasamno gene. So this is, you can say, gene therapy. SMN1 gene replacement given by adenovirus 9 vector. Indicated population less than 2 years. One-time injection systemic delivery may not be effective in response of anti-adenovirus antibodies. So you can say the drugs nusinersen and risdiplam, they are affecting at the level of SMN2 gene, and they are helping the SMN2 to make more of functional SMN protein. Whereas onasemno gene, which is a gene therapy, it is increasing the levels of SMN1 gene. So just a short summary, risdiplam, all SMA types, children more than 2 months, given orally. Spinraza, or you can say nusinersen, all SMA types, all ages, but given intrathecally. Zolgensma, onasemnogene, all SMA types, children younger than 2 years, but given intravenously. So last in the causes of SMA, one of the last differential of SMA is infantile botulism. Always you can think one, you can cap as a last differential diagnosis. This botulism occurring in the infants less than 6 months of age due to the infection of gut by Clostridium botulinum with subsequent in vivo production of the toxins. Toxins are then absorbed into the bloodstream and taken throughout the body, causing paralysis by blocking the release of acetylcholine at the neuromuscular junction. So this is a disease which is at the level of neuromuscular junction, as I told you earlier. Important features: constipation, lethargy, weakness, difficulty feeding, altered cry. And what type of paralysis there? Descending flaccid paralysis. Descending flaccid paralysis is there in infantile botulism. Treatment supportive, and important is botulinum immunoglobulin. This can bind free toxin. This can may halt the progression of disease and shorten the length of hospitalization. So this was the part of floppy baby